This year, the Bardhan lecture will be delivered by Professor Ailsa Hart, and she's very kindly shared some photos to give us an insight into her life. So Ailsa was born in Durham. Her mother and her grandfather were both doctors. She enjoyed her family holidays, and you can see here, young Ailsa was coming out of the toilet tent. Little did she know that she was going to become a gastroenterologist. The young Ailsa had a passion for both violin and ballet, and it was really quite a tough decision for her between dance school and medical school, but medical school won. Ailsa went to medical school in Oxford, and no surprises, was awarded a first-class honours degree. She also was Derek Jewell's house officer, and that gave her the inspiration to do gastroenterology. She got her PhD with Imperial College, followed by a Wellcome Trust Fellowship with Professor Michael Kam, who was also an important person and a mentor in her life. She's been a consultant gastroenterologist in St. Mark's, and also the sub-dean of St. Mark's Hospital Academic Institute in London. In 2016, at a very young age, Ailsa got her chair and became professor in gastroenterology at Imperial. She's also an honorary professor in Denmark. But despite all her busy academic achievements, she continues to do her hobbies, and this is Ailsa doing fly fishing. Ailsa has so many achievements, which I just cannot summarize with just one slide. She's trained many gastroenterologists. Some of you might be in the audience. She's published book chapters and over 240 papers, reviews and book chapters. She's currently on the governing board of ECHO, and I think she's got a meeting to catch up later on today. She's also on the IBD Clinical Research Group Committee for BSG, and she's been the past chair of the gut microbiota for health group of the BSG. She is the UK Patient and Public Involvement Lead for Gastroenterology. She's also been on the research committee for Crohn's and Colitis UK. And finally, she's a member of the International Organization for the Study of IBD. I asked Ailsa for what are her mottos, and she told me that she really liked to be the desire to be extraordinarily ordinary. Ailsa's anything but ordinary, and I'm sure you all agree with me. And her other quote is that the art of managing IBD is not getting the best algorithm or drugs, but really making the patient feel understood, listened, and valued. And with that, I'd like to invite Ailsa Hart to give the Bardhan Lecture of 2021.
Thanks very much indeed, Rena, for that invitation. Very embarrassing seeing me coming out of the toilet tent when I was a child. And thanks very much to David and the team for this invitation to this truly excellent meeting. It's a real pleasure to be with you all in person today. And it's a great honour to be giving the Bardhan Lecture. I've always respected Professor Bardhan for his commitment and incredible contributions to gastroenterology over a really prolonged period of time, so thank you. So the title of this talk is Goal Setting and Optimising Management of Fistulising Perineal Crohn's Disease. And I'd like to start on a historical note. So the hospital, St. Mark's Hospital, was first founded in 1835 by Frederick Salmon. And it's a picture of him in the top left corner of this slide. And the middle slide is an early picture of the hospital when it had the rather snappy title of the Infirmary for the Relief of the Poor Afflicted with Fistula and Other Diseases of the Rectum. Doesn't really trip off the tongue. But nonetheless, that was the time, of course, in Victorian London when these hospitals were side by side as charity hospitals to actually try and help the poor. Now, who knows who the photo the next along is of? Does anyone know who that photo's of? Well, it's Charles Dickens, the novelist, who himself had a fistula, which he put down to too much sitting at his desk. So maybe we need to be grateful that he spent a lot of time at his desk, because otherwise we wouldn't have all the great novels he wrote. But it was actually Frederick Salmon, the surgeon, who operated successfully on his fistula. And as a thank you to the hospital, Dickens gave the hospital very signed copies of his books, which the hospital then carelessly lost over the ensuing years. So thanks for that. But actually, Salmon was a very successful surgeon. He did about 3,500 operations on fistulas, amongst other things, over his time, without any fatalities. And of course, this was at a time when we didn't really have antiseptics or indeed anaesthetics as we know them. Now, the next picture along is Sir Alan Parkes, and we'll talk a bit more about him later on, because of course he gave his name to a classification for fistulas. And at the bottom is one of my favourite photographs of St Mark's Hospital. And if you look very carefully behind the trees, you can see it says St Mark's Hospital for Fistulas. So maybe it's very apt that I'm talking to you today about fistula management. So perineal Crohn's disease remains in the top 10 research priorities in inflammatory bowel disease. Now, this was an initiative we did some years ago now, and it was what's called a priority setting partnership, when groups came together to try and work out the top 10 research priorities for treating inflammatory bowel disease. And what was really nice about this initiative is it was surgeons, gastroenterologists, nurses, really importantly patients, and really importantly no commercial input that made these top 10 priorities come up. And you can just cast your eye down that list, but you can see that number 5 on this list was trying to optimise the management of perineal Crohn's disease. So it's a common problem. It was first described in 1938 in combination with regional enteritis, and around a third of our patients will have a fistula, and you can see how it accumulates over time for these patients. Very importantly, it can be the very first manifestation of inflammatory bowel disease, and really importantly, it can be the sole manifestation of Crohn's disease. This means we can turn these patients inside out and don't find any other luminal involvement. It's purely the perineal disease which is there. It's a small minority of patients. Now, the pathogenesis of this condition is still very poorly understood. This is a slide that Phil Tozer, one of my excellent surgical colleagues in the hospital, put together when he was my research fellow some years ago. And it tries to help us see sort of the two sides of the coin here. So on the right-hand side is all the factors we might associate with pathogenesis of IBD. So the factors that create, if you like, the hostile environment, the cytokines, the microbiological push, and indeed that failure of a wound to repair. But I might challenge you today that the reason we can't make much more progress in managing this condition is that we need to marry it up with the other side of the coin, which is the factors on the other side, slightly more anatomical factors, if you like. So the top one is the fact that most fistula tracts are epithelialized. So unless actually the surgeons get in and really scrape out and curatize those tracts, we can't actually get deep healing of them. The next point down is that you can't actually heal within a cylinder. And our surgical colleagues tell us that if you lay open a fistula, a simple fistula, it will heal, but it can't actually heal with the physics of healing in a cylindrical shape. So either filling that space or opening are ways to enhance healing. And of course, the anus is a high-pressure zone, and it's very difficult for fistulas to heal. We know that upstream in the gut, within the context of a high-pressure zone. So maybe by trying to actually wed together the immunological factors with some of these other factors might mean we can make more progress in treating this difficult condition. But let's now just look at a couple of cases. The first one is a fairly straightforward case, a man in his 40s who had intercurrent abscesses actually over a fairly long period of time, about 5 years, recurrent abscesses that he went to his local A&E to have drained. And then in 2017, pre-pandemic, happy days, he went on holiday to Barbados. But he described one of the most difficult plane rides of his life coming back with a large perineal abscess. When he got back to the UK, he had an EUA, had a aceton inserted, and he was given some antibiotics. And it was then that it became apparent, so 5 years after the initial symptoms, that he did actually have Crohn's disease with some ileal and rectal involvement. And off he went on to very standard therapy with thiopurines and infliximab. But then he had this struggling course of disease. For 3 years, he's getting more and more symptoms, and life was pretty much going downhill. So the levels of drug were checked, the infliximab was optimized, but actually it was deemed that he lost response. So he switched to adalimumab, a second anti-TNF, and again, loss of response. So just think about what next. What drug is going to be the next thing you'd be thinking about for this sort of case? While you're thinking about that, I'll tell you about a second case. So this is a young man this time, an 18-year-old. He came in under the surgical team, again, a very similar presentation with an abscess, a possible fistula. That was drained by the on-call team, and off he went home with antibiotics. No particular symptoms otherwise. He smoked intermittently, and you can see the blood test there, just a slightly raised inflammatory marker. Now, a very astute surgical trainee sent off a fecal calprotectin from casualty that night, and it came back elevated. So immediately this patient got into the hands of the gastroenterologist, had a scope and a scan, and was diagnosed with Crohn's disease. So an early diagnosis, back into the hands of the dedicated colorectal team, and off he went with his seat on, dual therapy, and over a longer period of time, he actually did extremely well and indeed healed the fistula. So 2 different cases, just to keep in your mind as we talk through the rest of this presentation. And I'll give you 6 steps to try and optimize the management of this. The first one is trying to get a prompt diagnosis. The second one alludes to setting goals of therapy with the patients, outcomes to aim for. I'm just going to share with you a new classification that we're thinking about at the moment, and then how to optimize assessment, the medical surgical management, and really importantly, service delivery for this difficult condition. So the first point about avoiding diagnostic delay. Well, this is a paper that Kapil Sanan, one of my fellows from a few years ago, put together. And the first point to note is that out of 165,000 patients, it's only a really small number of patients who had Crohn's disease out of all of those patients with abscesses. So I think as gastroenterologists, we always think that any perineal abscess is Crohn's, but it makes a very clear point that the vast majority are not. The second point I think this slide makes is that while most of the patients have a diagnosis of Crohn's and then develop a perianal abscess or problem, there is still a significant group of patients who actually have their abscess as the very first manifestation, and it can take a long time to actually get to the diagnosis of Crohn's disease, maybe a median of about a year to actually come to diagnosis. So how can we actually think about this? Well, it's recognizing that, of course, perianal trouble can be the initial manifestation. And I think as gastroenterologists, we really do need to make sure that we owe it to our colleagues to try and educate those who first interact with these patients to consider Crohn's as the diagnosis. That's primary care and the patients, the people who see these patients in A&E. By taking a full history, of course, of luminal symptoms, very importantly about asking about extraintestinal manifestations, and really importantly a family history of Crohn's disease or ulcerative colitis, which often gives the game away. And then they have full investigations, bloods, calprotectins, scopes, and often a capsule can be helpful as well. What about goals of therapy? What are we actually aiming for here? Well, if you look to the literature, and we did a systematic review some years ago now, there's an absolute raft of outcomes you find in the literature for measuring outcomes from perianal Crohn's disease. Closure of the external opening or the internal opening or both openings, and the list really does go on. And it struck us a few years ago that we needed to think more shrewdly about this and develop what's called a core outcome set, and this was using a Delphi methodology. So you might recognise a few of the faces in here. We've got Steve Brown, I think Matt Lee's there, and Alan Lobo's there as well. So very much a team effort. And again, importantly, this group was not just surgeons, gastroenterologists, nurses, radiologists, but also patients who came together to develop this core outcome set. And this is what the core outcome set came out as. And you can see in the box 2 there, the particular aspects of it, not to be read in detail, but these, if you like, are the key things now to try and speak a common language for every trial that goes on now for perianal Crohn's disease, to use these core outcomes, which of course we then need to translate into some core measurement sets. So it's had patient-related outcomes, clinician outcomes, and importantly, imaging outcomes as well. But one of those aspects was to try and measure quality of life. And I think arguably it might be one of the most important aspects of measuring what's going on in these patients. And what I'm showing you here is some work that Sam Adegbola, again one of the research fellows who worked with me, did a few years ago and has just reported. It was called the CAF-QOL, or the Crohn's Anal Fistula Quality of Life Questionnaire. And what he very clearly demonstrated, and again this was working with qualitative research with a large group of patients, was that it was burden of symptoms, the burden of the treatment, and the negative impact on well-being, these factors that came together in the design of this particular questionnaire. Now, again, it's not to be looked at in detail, but I think it's often helpful to look at these sorts of quality of life questionnaires and read the questions in them. I think maybe at the very least it's trying to encourage us as gastroenterologists not just to ask about pain and discharge of these patients, but then to find the words with patients to ask what's impacting on them, how's it actually affecting their day-to-day life, what's it limiting them doing, how's it making them feel. Those sorts of open questions can then just open up with what the real impact of the disease is on them, which can help kind of steer how the management goes beyond that. So these are the sorts of outcomes we're thinking about. But let me now share with you a new classification for perineal Crohn's disease. Because, of course, what we have so far is a whole load of different classifications. The vast majority of them actually focus on the morphology of the fistula tract. Some, like the Perineal Disease Activity Index, they do allude to disease activity as well, but the vast majority is purely morphology, with maybe arguably no real clinical relevance. So the group put this together, and it was particularly led by Phil Tozer, who you can see on the left there, again with a group of surgeons, gastroenterologists and radiologists, predominantly from Europe, but also from America. So this is what we're proposing here, and this is work submitted at the moment. I'll just walk you through this particular classification. So broadly speaking, we're saying there are 4 different groups or classes that every patient that you see with perineal Crohn's disease will fit into. So class 1, it's a group with minimal disease and minimal impact overall on their quality of life and needing minimal therapy, an easy one to deal with. So some of these fistulas are genuinely just indolent and don't need much doing with them. Then in class 2, this is the vast majority of the patients who we see in our clinics. So this is the patients with chronic symptomatic fistulae. And really this depends on a couple of key things, which group they then fall into out of the group A, B, and C, depending really importantly on the goal that patient wants to achieve, as well as their symptoms and the quality of life issues, and then some factors relating to the anorectum and what the anatomy of the fistula is. And when those things are taken into account, they fall into 2A, which is a group who've got the symptoms, but mutually it is felt that there is a chance of actually repairing the fistula tract surgically or medically, and importantly, the patient wants to achieve that goal. They're prepared to go through several hoops, maybe several operations to actually achieve that. Not all patients want to do that. In contrast, in class 2B, is the group of patients, again with the chronic symptoms, who maybe don't want to go through all those hoops, where just palliation or control of the symptoms is the goal there. And maybe that's again where the sort of CAFCOL or the quality of life questionnaire can help with guiding that. Class 2C is a group of patients who've got much more difficult disease. And we all know there's one group with really difficult early progressive disease who often come to a stoma fairly early on. But the other group is the ones who are just gently drifting in the direction of needing the defunctioning. So that's a more difficult group to treat. Class 3, we've given it this title of an exhausted perineum with adverse features. So this is the group where just defunctioning isn't enough for the patients and they come to proctectomy. And the final thing just to note, of course, is that proctectomy often isn't the end game for these patients. They can still often have an unhealed wound, which can again need various surgical or medical intervention, again dependent on the patient goals. So just some thoughts on a new classification there. What about assessment? How do we optimise that? Well, of course, the major modalities we use are radiology, in MRI imaging, endoscopy, and of course an EUA for our surgeons to do. And all of this has got to happen, of course, in the context of their luminal disease, the symptom burden and the patient goals. And I think as gastroenterologists, we often see these black and white imaging things. It's really hard to visualise what fistulas are like. And some of these new sort of 3D ways of looking can really help us understand what fistulas are up to. So in the imaging I'm showing you here, in red is the fistula tract, and you can see this very dramatic fistula tract really going through the levator plate and absolutely horseshoeing around. I think these sorts of pictures help us, for sure, to visualise a lot more what's going on. There are various other ways that this can be done. There are some of the top images that surgeons can even get beamed into their phone during operations to help them understand where things are. And in the bottom is a 3D printout, which our radiologist actually did. It took him about 20 hours to print this out on the 3D printer. And when he gave it to me, sadly, the fistula tract dropped off, which was a bit embarrassing. But nonetheless, it makes the point that you can actually get something a little bit better to maybe even help our patients visualize what's going on and what we're trying to achieve with this. It can be a very hard concept to get their heads around. Finally here, I'll just see if I can give you a fly-through, if I can get the video running, a fly-through a fistula tract. Now, I bet not many of you have been through a fistula tract, but here we go. We're going through the fistula tract. We're going through past the external sphincter muscle opening. Then we come past the internal sphincter opening, and this might just be a bit of fun for us, but of course for our surgical colleagues, it's really helpful to know where any branches are in relation to the fistula tracts. And the final point I'd like to make about assessment is that when we get radiology reports, we often get back that it's a little bit worse or a little bit better, but very little to really help us understand the true direction of travel. So one proposal is to measure the volume of those tracts and use that as something quantitative to actually help us understand it. And this is very much work in progress at the moment. So optimising the medical and surgical management. Well, I'll just put up for you the ECHO guidelines here. So these are guidelines, and I think it's really quite interesting to note when you look at guidelines, when you use grade methodology, it's looking at very high-level evidence for what's going on. And I think the striking thing with perineal Crohn's disease is how limited the data is. Because if you again just read through the list there, it's only infliximab that really comes out, because that's where the evidence actually is. Now, of course, that's not very helpful for us as clinicians, but you can see there that actually monotherapy with antibiotics, monotherapy with thiopurines certainly doesn't hit the grade methodology. Again, just showing you the ECHO recommendations from the surgical perspective, and here we use Oxford methodology rather than the grade methodology because the evidence just isn't there at all otherwise. But I think a key point is there are no prospective studies directly comparing medical or surgical treatment or indeed combinations of those. But nonetheless, observational studies do support a combined medical-surgical approach. You can see that advancement flaps or lift operations, they certainly do cut the mustard there. Glues and plugs, fairly limited evidence there, and a bit of data on stem cells, which I'll share with you in a moment. So that's the guidelines, but I think it's probably more helpful to think about some very clear clinical recommendations. And the first box very much makes the point that combination therapy, even this is outside strict evidence, combining therapy with infliximab and thiopurines is advocated. Why? Because we really need to squeeze the most out of infliximab as a drug to mitigate losing response because of immunogenicity. And of course, some of our patients have already been through anti-TNFs by the time they present with their fistula, so we need to think about therapies with other agents like ustekinumab or vedolizumab. The second box along, I think, makes a clinical point of working really, really hard with infliximab. Don't assume loss of response to the drug until you've done two very clear things. One is get another MRI scan to check there aren't any branches or pockets of something that needs addressing. And two is engage with the surgical team, again, to see if they can curettage things out and make the field a bit better for the drug then to come in and work. So don't call loss of response to the drug until maybe those two things have been done. The next box along is timely restarting the biologic after an EUA. When we audited our practice a while ago, there were embarrassing delays actually with patients having had an EUA, then waiting a long time before they got back into their biologic drug. They can pretty much get straight onto the drug again after they've had an EUA. The next box down is just a caution about some of the words that we see in our radiology report. Sometimes we see words like collection or cavity or abscess. Link with the radiologist to see what is really meant here, because sometimes it's not an actual abscess that needs draining, it's just some disease, and actually not giving the patient a biologic is probably more detrimental than giving it in some of these circumstances. The next box along makes the point about linking with the surgeon to make sure that if patients do become more suitable for surgical repair, we can get them to the surgeon. And conversely, we can link with the surgeons with various techniques they can use, like VAFT or Phylax, some of these techniques to help the patient's symptoms and keep in mind the goals of therapy as we go. So coming back to this overall classification, if I just highlight the 2A and the 2B groups, it really does depend on the surgeon and the gastroenterologist working together, because patients can flow in and out of these different groups and things can evolve throughout the disease course of the patient. Just a word about stem cells, because of course this is where we've got some good data. This is the ADMIRE CD study, a phase 3 multi-centre trial in over 200 patients with perineal Crohn's. A longish duration of disease, and you can see the types of patients that went into this study. They all had a baseline MRI, and it's rather important just to hear what happened to the patients, because in all these patients they had very good surgical therapy. So the tract was curetted, a ceton was inserted, and then 2 weeks later, a ceton was removed, the internal opening was sewn up, and the stem cells were injected. And the definition of closure in this group was combined remission, looking both radiologically and clinically. And you can see this particular data here, that patients do very well with stem cells. It's a significant result. But I think the striking thing is also that the group in the surgery alone group do pretty well compared with a lot of the other therapies we've looked at. Now, it might look as if I'm switching tack big time here, but just a word about graft versus host disease, because, of course, mesenchymal stem cells are very much the treatment of choice to treat graft versus host disease. And there are some analogies that you can see even by looking at the pictures of patients who get this disease. What's really interesting in graft versus host disease and using stem cells is that you can pull out the patients who do really well by doing this apoptosis assay. So what's done in this particular assay is peripheral blood mononuclear cells are taken, they're co-cultured with mesenchymal stem cells, put into this assay, and you can see the patients who do well in graft versus host disease, who respond, that's the R in this particular diagram at the bottom, they're the ones who've got the high apoptosis assay. So it looks like there might be something which can help understand which patients respond or don't respond to this sort of therapy in a different disease. So we asked ourselves in perineal Crohn's disease, is anything vaguely analogous? So again, we looked at peripheral blood mononuclear cells and co-cultured them with mesenchymal stem cells. And although it's very early data, there was a sense that patients, again, who had this high apoptosis assay, did better with regards to stem cells in perineal disease than those with the low apoptosis assay. So I think what this is trying to tell us is, can we maybe be smarter at how we use an expensive therapy like stem cells to try and actually use it in a group of patients who are more likely to respond. So early data, but something that may yield something a bit interesting in due course. Now finally, just flipping back to those cases, remember the man I told you about, the guy who'd had horrible symptoms for about 5 years, an awful abscess on the way back from Barbados. What was going on? He'd had 2 anti-TNFs. What are we going to do next? Well, what we did was we did a scan, exactly as I suggested to you. We did a scan, and if I just scroll through the video of this, he had a very surgically remediable fistula, actually, when the scan was done. So it was a transficteric fistula that Janindra, my surgical colleague, could actually operate on. It actually healed, and he did really well. So the answer here was not just to flip to ustekinumab or vedolizumab, it was to do a scan, engage the surgeon, and actually he'd become a 2A patient. He had a fistula which was very much surgically correctable. So what was wrong with this patient? Well, there was a big diagnostic delay. There was actually poor communication within the team, and he was really struggling. He didn't get the psychological support he needed. In contrast, just to think about that other case I showed you when that surgical registrar on call got the calprotectin off really promptly, prompt diagnosis, rapidly onto therapy, and this patient did really well. Finally, service delivery. And I think, we all struggle with trying to get our services to deliver all the time to all patients. It is really, really hard. One thing that we found works quite well for this group of patients is this genuine joint consultation. So not the patient seeing the gastroenterologist then wandering over to the corridor to see the surgeon, but actually Phil Tozer or Janindra and myself sitting in the clinic room together with these patients, really trying to work through what are the goals of the patient, is there anything surgically correctable or palliatable or not, and trying to get the best for all patients. Patients love it. They really do like this sort of consultation. They get a consistent message about their care rather than feeling slightly different views from different clinicians. Final slide on clinical trials. I think the whole point of that classification thought was to maybe be smarter about the groups we put into clinical trials. I think maybe one of the reasons that clinical trials have been so difficult in this area is that it's a really heterogeneous group of patients we put in. Improve the measurements that we make with things like the core measurement sets that we're working on, and maybe develop strategy trials. We really are trying to link a certain surgery plus a certain drug together, trying to get both sides of that diagram coming together. And I think it is important to have quality of life assessment in these patients. Of course, keep exploring pathogenesis and biomarkers. So, in summary, I think prompt diagnosis is really important. Use every possible opportunity as gastroenterologists to educate general practitioners, A&E people, the people who really see these patients to start with. Talk to the patients, listen to them about their goals. Their goals can evolve over time. I've shared with you a new classification to help frame clinical decision making, but maybe also for trials and research. There are exciting new ways that the surgeons, all of these toys the surgeons are used to actually visualize fistulas. Medical and surgical therapies really do genuinely work hand in hand here, but don't forget the psychological support. It's probably the most forgotten bit of inflammatory bowel disease. And think about how to deliver the service. Thanks very much indeed for your attention.
Thank you, Ailsa, for delivering a tour de force for this year's Bardhan's lecture. As is convention, there aren't any questions at this time. We're delighted now to award you the Bardhan Prize, which Rena and Mo will present to you right now.